My name is Amy Tyberg, and I am currently an assistant professor of medicine at Weill Cornell Medical Center, Division of Gastroenterology and Hepatology, and Subdivision of Advanced Endoscopy. The study I am talking about is entitled Endoscopic Ultrasound-Guided Biliary Drainage After Failed ERCP, a Novel Algorithm Individualized Based on Patient Anatomy. This study was recently published in GIE in May of this year. The impetus for this study came from the need to standardize a new endoscopic technique that has emerged into the GI armamentarium. The field of advanced endoscopy is rapidly expanding. Innovative and novel ways of caring for patients in a minimally invasive fashion continue to emerge. It's an exciting time in our field, inspiring creativity amongst endoscopists and industry, developing new techniques and technologies to advance the field and improve patient care. However, as these new and innovative procedures emerge, a variety of different techniques are utilized and shared in the literature throughout the learning process. Over time, as endoscopists gain knowledge and expertise, a standardization of technique becomes a requirement, both in order to assess efficacy and safety of the new procedure when compared to the current standard techniques on a large-scale basis, as well as to allow for widespread adoption of the procedure amongst colleague endoscopists. Such is the case with endoscopic ultrasound-guided biliary drainage. Since 2002, multiple case reports and case series, and more recently even some multi-center reviews, have consistently demonstrated this new procedure to be efficacious and safe, and at least comparable, if not superior, to the percutaneous and surgical alternatives. However, multiple different approaches can be used to achieve biliary drainage using endoscopic ultrasound guidance, both in terms of how to approach the biliary tree from an intrahepatic puncture site versus an extrahepatic puncture site, as well as in terms of the type of drainage stent placed. Anterograde transpapillary stent placement, where the stent is pushed from the intrahepatics down the biliary tree and across the ampulla, and then deployed with the distal end in the small intestine and the proximal end in the biliary tree. A rendezvous ERCP technique, where the wire is advanced across the ampulla anastomosis into the small valve, and then left in place as the EUS scope is removed and a standard duodenoscope is inserted, used to grasp the wire and pull it through the working channel, after which conventional ERCP is performed. Or transluminal stent placement, where the stent is deployed with the distal end in the biliary tree and the proximal end in the small valve. While several studies have attempted to compare these different approaches, the results have been inconsistent and inconclusive, and ultimately no clear consensus on the optimal strategy exists. In order to address this issue, our team at Cornell adopted a new algorithm that uses patient anatomy to determine the ideal approach, as illustrated on this schematic here. Patients with dilated intrahepatic ducts underwent an intrahepatic approach with the goal to achieve transpapillary stent placement to preserve natural anatomy and reversion to hepaticogastrostomy stent placement when the ampulla or anastomosis could not be crossed. Similarly, patients with non-dilated intrahepatic ducts underwent an extrahepatic approach with the goal of transpapillary wire crossing and rendezvous ERCP when feasible, with transluminal stent placement in cases where the ampulla or anastomosis could not be crossed. Using such an algorithm obviates any personal endoscopist bias or expertise in choosing one approach over another and allows for a much-needed standardization that can now be applied on a wide-scale basis amongst other therapeutic endoscopists. Using this algorithm in 52 consecutive patients at our center from 2011 to the present, who failed conventional ERCP, we documented excellent technical success at 96% and a low adverse event rate at 10%, comparable and even potentially superior to published results. Here at Cornell, we are excited about the rapidly expanding field of advanced endoscopy, and we cannot wait to continue to push the envelope and challenge our creativity to find new ways to help patients in the least invasive means possible. However, we also recognize that innovation is only as good as its ability to be adopted on a wide-scale basis, and such a process requires standardization of technique. We truly believe that by using this algorithm for endoscopic ultrasound-guided biliary drainage that standardizes technique based on patient anatomy, This procedure can become firmly established in the advanced endoscopy armamentarium for patients who fail conventional ERCP.